Hello, my name is Dr. Daniel Cohen, and I'm a gastroenterologist and the head of the GI Motility Service here at Shamir Medical Center in Israel. And I want to thank Gastrointestinal Endoscopy and the ASG for the opportunity to discuss our manuscript and paper that was just recently published called The Effect of the Timing of Endoscopic Detorsion on Clinical Outcomes in Patients with Sigmoid Volvulus. Now, for all the gastroenterologists out there, you know that a sigmoid volvulus is one of those emergencies that when we're on call, we have to come in and do a procedure emergently. But what's the evidence for that? We all know that this happens, and what happened to me was about a year or so ago, I was on call, and there was a case in the middle of the night, and we got into a discussion about how quickly and how urgently the endoscopy has to be done. Does it have to be done in the middle of the night? Can it wait till the morning? Things like that. So that case made me decide to look into the literature and see what actually we know about that situation. So if you look through the different guidelines, the ASG has guidelines on sigmoid volvulus, and it says that in cases where there's no signs of perforation or ischemia on imaging, that endoscopic detorsion should be performed. But it doesn't say anything about the timing. And same with the American Society of Colorectal Surgeons. Their guidelines don't say anything about the timing. The World Society of Emergency Surgeons does say that the endoscopy should be performed urgently. And they use the term urgently, but again, there's no data supporting where they come up with that suggestion. In fact, as far as we can tell, there's only been one study that's looked at the timing of when endoscopic detorsion is performed and outcomes. That study was only published as an abstract, so there's not many details as to exactly what their methodology was and how they came up with their results, but they said waiting more than 8.5 hours after the time from which sigmoid volvulus is diagnosed on imaging until when the endoscopy is performed, waiting more than 8.5 hours is associated with poor outcomes. But again, it's not exactly clear because that was only published as an abstract. So that made us think, well, what really do data show on this? And that's how we came up with our study. Our study was a single center retrospective study performed here at Shamir Medical Center. We looked at all cases of volvulus from 2010 until 2024. So it was a significant time period. All the patients had to have sigmoid volvulus confirmed on an imaging study, either a CT scan or an abdominal x-ray. And all the patients had to have undergone endoscopic detorsion. We calculated the time, as was done in that prior abstract, from the time in which the imaging study was performed until the time in which the endoscopy was performed. And we looked at different outcomes to see whether or not the timing or the length of time until endoscopy was performed was associated with worse outcomes. The outcomes that we looked at were the success rate of the endoscopic detorsion, the presence of ischemia on endoscopy, the need for a repeat endoscopic detorsion procedure, the need for emergent or urgent surgery, the length of hospitalization, the 30-day readmission rate, the 30-day mortality rate, and the inpatient mortality rate. In addition, we combined several of these variables into a combined serious outcomes measure that included any signs of ischemia, urgent or emergent surgery, or inpatient or 30-day mortality. In terms of our results, there were 118 cases that met the inclusion criteria, and those came from 73 unique patients. As I mentioned before, each admission was looked at individually, so there were some patients that had multiple admissions that were included in those 118 cases. The mean age was 69 years old and 76% were men. The median time from in which the sigmoid volvulus was diagnosed until the endoscopic detorsion was 225 minutes. That's 3 hours and 45 minutes as the median amount of time. Most cases, 68%, were done in less than 6 hours, and half of the cases were done while on call. Out of the 118 cases, 110 of them were successfully detorsed endoscopically. That's 93.2%. On the endoscopy, 11 cases had ischemia noted. That's 9.3% had ischemia. So we looked to see what were the risk factors for having ischemia on the endoscopy and whether or not the length of time was associated with that. We noticed that the ischemia group was more likely to have had their endoscopy procedure performed while on call. They were more likely to undergo urgent or emergent surgery. They had a longer length of hospitalization, but there was no statistically significant difference in terms of mortality or the timing of the endoscopy procedure for those patients that had ischemia. So we looked at it in terms of those with ischemia and not, as well as using the time for detorsion as a continuous variable. And again, the time of the endoscopic detorsion was not associated with the finding of ischemia. Next, we looked at whether or not the patient's index visit was associated with those findings or not. And when we compared patients on their index visit as opposed to subsequent visits for sigmoid volvulus, there were no differences, except patients on their index visit were more likely to have a CT, and on follow-up visits, the likelihood of just having an abdominal X-ray increased. Next, we looked at the timing of endoscopic detorsion to see how that was associated with patient outcomes. We divided first all the patients into those that had the procedure done in less than 6 hours versus those with more than 6 hours until they had their endoscopic detorsion performed. Those that had the delayed endoscopic detortion were more likely to be younger and had had a rectal tube placed prior to the procedure. We noticed that those that had the longer period had a longer length of admission, but no other outcomes, patient outcomes were worse in terms of mortality, ischemia, or emergency surgery. Next, we divided the entire cohort into 4 groups: those less than 3 hours, between 3 and 6 hours, between 6 and 12 hours, and more than 12 hours. And again, when we compared each of those groups to the group that was less than 3 hours, the longer period groups, the 6 to 12 hours, and the greater than 12-hour groups had longer lengths of hospitalization, but they did not have any more ischemia. We also looked at the combined serious outcome variable, and again, those longer duration groups did not have that either. They also did not have any worse success rate in terms of endoscopic detorsion. Finally, we did multivariate regression analysis, including age, timing of detortion, and on-call status. And the only thing that was associated with the combined serious outcomes was being on call, but not having a longer length of time until the endoscopic detortion was performed. So in conclusion, our findings showed that delaying the timing of the endoscopic detorsion did not appear to be associated with any worse outcomes other than longer hospitalization length. But in terms of ischemia, mortality, or urgent or emergent surgery, none of those were associated with having a longer wait until the endoscopy. In conclusion, this large series of patients with sigmoid volvulus, we did not find any correlation to worse outcomes with a longer delay in terms of the timing of endoscopic detortion. Only the length of hospitalization was increased, and ideally there should be further prospective studies evaluating really how long patients can wait and in which cases in patients does endoscopy not need to necessarily be performed emergently. Thank you.